Welcome everyone. Thank you for joining us for our Ultrasound and the Experts webinar today. My name is Lihailatin Pradit. I am a clinical and education and application Ultrasound team from Thailand. Today, we have very well-known speaker, Dr. Nicholas Fenning, who are presenting in the topic 3D ultrasound in reproductive medicine. This webinar session will cover how to get the best 2D image, how to acquire the best volume, and using the multiplanar view to standardize how to render and apply omnic view, and including about the automation tools for evaluate the volume of the ovary with Sono AVC. Before we get started, please check your audio volume. At the audio tab, select the mic and speaker from the drop-down list menu that you can see at the right-hand side in the screen. And if you have any question during the presentation, please type them into the question box in your window. We will also have time for question at the end. And about our speaker today, Dr. Nicholas Fenning works as a consultant gynecology and reader, associate professor of the reproductive medicine and surgery at the Queen's Medical Center in Nottingham in UK. Clinically, he managed women with benign gynecological pathology and subfertility, including patients requiring IVF treatment. He is a director of research for the Assisted Conception Unit and reads for the Academic Image Suite. Dr. Nick, an internationally recognized as the expert in three-dimensional ultrasound and gynecological imaging, and has given over 100 invite talks, plenary sessions, and workshops. He was awarded a PhD in 2004. Work for relating to the qualification of pelvic butthole. He is a member of a board of the International Society for Ultrasound in Obstetrics and Gynecology and leads to the reproductive medicine component of the gynecology focus groups. Reminder again, if you have any question during the presentation, please type the question into the box and click send. We will also have time for questions at the end. Now, without further ado, I will turn the time over to Dr. Nick in the topic that we'll discuss today. Welcome, Dr. Nick.
Good morning. Thank you very much. Let me just find my presentation. There we go. Super. Well, thank you very much for that kind introduction, and thank you to the whole team at GE for putting on this webinar. It's a real pleasure to speak on your behalf and to speak to all of the attendees today. I hope that you are all well and your families are well in this strange and uncertain time. We're going to have more and more webinars, so it's really good that GE have taken the lead on this, and I know there's a series of webinars they've prepared for you, and I'm just delighted to be able to do one of them. Again, I won't go into too much detail about my background, but I'm a gynecologist by heart. I'm an academic, so I spend half my time doing research and half my time doing clinical work, most of which is really fertility and primarily IVF. I also do general gynecology, laparoscopic and general surgery, but mainly within the concept of reproductive medicine, so fibroids, polyps, uterine abnormalities, and so on. I've been asked to talk to you today more specifically about IVF. Now, I know not all of you are IVF practitioners, but I'm sure that some of you are, and some of you that are involved in fertility will be referring patients on to IVF clinics. So I think hopefully what I'm going to share with you will resonate and have relevance for all of your work. And what I wanted to do is really just take you through what we do every day, 7 days a week in my unit. We work Saturday, Sundays. That's more for the general monitoring of patients, but certainly Monday to Friday, what I'm going to share with you is exactly what we do every day and have done for many years. We're part of a much bigger group called the Fertility Partnership. It's now the largest provider of IVF within Northern Europe. So we're the biggest in the UK, but also have many clinics now through Northern Europe. So that's good because we've got the ability to cross share information and so on. But what we're very proud of is that this is Robin Hood. You may have heard of Nottingham for Robin Hood and the evil sheriff of Nottingham, which is only a fairy tale, of course. But just to show you some stats. So again, these vary all the time, but we are overseen by the HFEA. So every cycle started is registered, and we can see here that we outperform the national success rates by quite a long way, irrespective of whether you're under 38 or all ages. And we've done that for a long time. Our average pregnancy rate, live birth rates, just under 50% for patients under 35, which is pretty good. We'd like it to be higher, and we shall continue to do that. We do consistently well, whether it's under 35, over 35, whether we use fresh embryos or frozen embryos. And part of that, of course, most of it is the team. A lot is our patients, although we have a very open door policy here. But I do think ultrasound is a critical part of it, and I'm going to show you why and hopefully convince you if you're not already convinced. So these are the sort of key parts of an IVF journey: baseline assessment, and then what protocols we put people on, how to determine what we're going to use to maximize response in a safe way, how do we monitor response, then briefly a little bit about egg collection, embryo transfer, and I'll focus a little bit more about receptivity. So what is it that makes the uterus best suited to accept the embryo or embryos are replaced, and then finally, again, just briefly a little bit about early pregnancy and how ultrasound can help there as well. So let's begin with pre-treatment assessment, and this has got relevance for all of you. Now, I show this slide quite a lot. It's just a brief summary of some of the things we can find. Now, I'm still amazed at really how little we know about all of these different pathologies. So we've got you know, variety of things you can see here: uterine abnormalities, endometrial polyps, cysts, ovarian cysts. We've got hemorrhagic cysts here, endometriomas. And then there's hydrosalpinx there you can see as well. So now some of these things you'll be saying to yourself, well, I know that's important, and you know these things have a negative effect. Do we really truly know the impact of some polyps? What about adenomyosis? A few years ago it was, well, you don't really need to worry about it, but actually there's more and more data that would say it actually has a negative effect on implantation, both spontaneously and through assisted conception. What about the polycystic ovary? Yes, there's lots of follicles and patients over respond, and I know that's a very particular issue that you struggle with and that you have a much higher prevalence of. But what we also know is a lot of these women have poor quality eggs. None of this you can tell really just from blood tests and from looking at the clinical phenotype. This is where ultrasound really comes into its own. So we've got to pick up pathology, maybe not necessarily worry about it, but we need to be advising patients accordingly. Sometimes there'll be surgical intervention, and sometimes there'll just be reassurance. And I'll give you a few examples. Again, we've known for a long time that if you have a hydrosalpinx, then that's going to reduce implantation naturally and with IVF by at least 40%. So if your embryo has got a 50% chance of implanting, which is roughly our average success rate, you're going to take that down to about 30%. That's a 20% loss. That's huge. That's really important. So there's certainly no way that we should be moving forward about treating these. Hydrosalpinges can be seen with 2D pretty easily, as you can see on the right, and you can render them.
Sorry, Dr. Nick. Sorry, I think your slide is not moving.
It is for me.
Yeah, still at the second slide, I think.
Oh, yeah, I see that. Yeah. I see that. Okay, why is that happening? Let me look at that. Let me try. That was a success. So let me go back to this video. It says paused on there. I don't know why it says that.
Maybe you can try to make it the slideshow.
Yeah, the videos won't work then in that case. I'm just trying to look at it here. Just come out of there. Try this again. Yeah, it says paused on there for some reason. I don't know why. That's working now, yeah?
Yes, it's working now.
I don't know how that happened. Sincere apologies, everybody. That was the slide I was showing you, some of the different pathologies you can see there. So, yeah, okay. Now I've got it. Let me just make sure I can see. Let me know if that happens again. Okay, I've got a video now. So, sincere apologies. So, this was the slide I was showing with different pathologies. So, we can see, as I mentioned, fibroids, polyps, uterine abnormalities, and so on. So, I'll just leave that for a second because I do think this is really important. What you're going to hear me say quite a lot is that we've got to get the best out of our machines. We've really got to make sure that we're using the machines to their full capability. I think too often we scan very quickly and we don't pay attention to detail. For me, there's too much emphasis on measuring things, measuring the size of a fibroid, measuring the endometrial thickness, the size of a cyst. Size is not really that important. It's the detailed information we get from the grayscale imaging, looking at tissue density. Again, we can see in the third image at the top, adenomyosis. It's often said that it's a very difficult diagnosis on ultrasound, and I wouldn't disagree with that, but I think that the more we look for it, and the more we get used to looking for normality, that if you can see a nice endometrial myometrial border, you can be confident that that lady is very unlikely to have adenomyosis. And then when you see an unclear border, as you can see here in the posterior wall of the uterus, it's very difficult to ascertain where the endometrium finishes and where it starts. You'll just naturally know that it doesn't look normal. You may not know what it is, but it's not normal, and I think that's really important. Okay, I think I've worked out what the problem is. Don't touch my cursors. This is the hydrosalpinx I was showing you. So we can see the video on the right is the 2D picture. It's a very easy diagnosis to make in many cases, but sometimes it can be tricky. If there's a small area, we often get asked, is it a hydrosalpinx? Could it be fluid within adhesions? Is it a cyst that's sort of slightly distorted? The rendering 3D will really, really help you, as you can see here. But for me, the most important image plane is this, which is the TUI imaging. So I'm going to show you how to do this, but you acquire a volume, very straightforward. If you've never done it, 30 seconds, very simple. And then you display a series of images. So this has been derived from the world of CT and MRI. So instead of one picture, we see a series of images. And again, you can see here that that is a classic hydrosalpinx. The first few images, you could understand why it must be mistaken for a simple cyst. But as we move through the volume, we can see the typical tube retort-like structure. So TUI, or tomographic ultrasound imaging, gives us this confidence that yes, it is a hydrosalpinx. And if we're going to stop treatment or we're going to refer somebody for surgery, you want to make sure that you know what you're dealing with. You don't want someone to have an unnecessary laparoscopy, but equally, you don't want to allow somebody to proceed with treatment if they have a hydrosalpinx, for the reasons I've stated earlier, that it's got a very significant detrimental effect. This is the same image of a cyst. We can see here that we've got sphericity in all images, so we can be confident that's a cyst and not a hydrosalpinx. And this is a para-ovarian cyst, so we can see the ovary medial to the cyst. So, you know, they're obvious pictures here, but I'm sure all of you have come across your practice where you have an ultrasound report or images and someone says to you, is it a cyst? Is it a para-ovarian cyst? Is it fluid within adhesions, or is it hydrosalpinx? And we've really got to be 100% on this. So basic 2D will help in most cases. If you're uncertain, acquire a volume and use the variety of image displays, multiplanar, TUI, rendering to improve your diagnostic confidence. And it really, really will help you. Indeed, I often say that when we have new staff in my unit, doctors or nurses, we always begin with 3D. They acquire a volume on everybody, so they get used to using 3D, because ultimately, when we're looking at 2D, we are creating a three-dimensional image. So start with 3D. It is the basic, not an advanced tool in my view. In terms of tubal patency, we can do a standard HiCoSy. So HiCoSys are very good, very straightforward. We've got an example here of a 4D HiCoSy and inversion mode to show the flow of the fluid. In my experience, we use 2D for most cases, but again, it's all about how you use 2D. It's very easy procedure, but you've got to be very good at scanning because it's all about very subtle movements of the ultrasound probe, very tiny micromillimeter movements to the left, to the right, so that you can track that fallopian tube, which we know has a convoluted flow to it. So you're unlikely just to see it in one plane. So I think even though the procedure itself is straightforward, the scanning level that you need to be able to confidently follow the dye so that you can confidently say the tube is patent or not, it is quite tricky actually in some cases. And this is just an example. So this is just a standard 2D picture. We can see we've inflated the balloon with saline, which is why the balloon is black and doesn't create shadow. We introduce the dye and you can see it very nicely flow down through both tubes there. And we then track it out slowly. Again, just notice how small the movements are so we can see the tube there on the right-hand side. And then we can see the tube on the left-hand side. So very straightforward. I've used a lot of 3D and 4D to try and help and improve. It does sometimes, but I think the diagnosis is quite clear in most cases on the basic 2D picture. But again, you can capture 3D volume and then see the tubes in their entirety here. Of course, there is a limitation of ultrasound, and it's things like this, which is the superficial disease of endometriosis, or as we can see on the right, the adhesions related to, in this case, pelvic inflammatory disease. Now, we often say, well, you can only really diagnose these things confidently by doing a laparoscopy. I don't think that's entirely true. There are some very good studies that look at mapping, so that how does the uterus move? Is the ovary mobile and is it tender? And again, the more that you scan, the more you'll get used to these things, and you'll be confident that yes, the uterus is fully mobile. There's no tenderness or minimal tenderness. And again, by doing lots of normal scans, you'll then know what is not normal. Same applies to picking up small deposits of endometriosis in the uterovesical fold or in the patch of Douglas. Just by recognizing it doesn't look normal, you'll then be able to see those deposits more clearly. So laparoscopy obviously has a role, not only for surgery, but for diagnosis, but don't underestimate the information you can get from ultrasound as well. What about these things? So fibroids are everyone's enemy. So fibroids are, we've talked about some obvious things so far. Hydrosalpinges, I think we're all pretty clear on that. Why is it we still know so little about fibroids? There's still debate about, how important are they? Do they affect fertility? And should we be removing them? And if so, how? It's a real shame that in 2021, we still have so little information when we've been scanning for 40 years. And we've had 3D for 25 of those years. So let's just have a little look at fibroids and see where we're up to. This is what I hear commonly, that the mural fibroid, which is the one on the left, is probably of no significance. People often ask me, what's the size? And again, focusing on the size of the fibroid is all important, not its location. And of course, with the image on the right, we have a submucosal fibroid that is indenting the endometrium. So this lady's in the menstrual phase, which is why the endometrium is so thin. There's a little bit of blood there, and that allows contrast, and we can see there is a submucosal fibroid. So I presume that many of you would say submucosal fibroids, we should be advising these are removed to improve fertility and reduce the risk of miscarriage, whereas the mural fibroids we can often leave unless there's many of them or they're above a certain size. And 2 centimeters is usually the size people talk about, and 4 centimeters again is sort of the upper limit. But is that actually true? Are mural fibroids innocent, and are submucosal fibroids all pathological? Well, the answer is it's still unclear. Now, this is a pretty old systematic review. There are more reviews since. They all say the same thing, so I think this is still has relevance. So what's a real shame is how few studies there are. So this one here is looking at the impact of submucosal fibroids, and you can see on clinical pregnancy, implantation, live birth rate, and miscarriage rate. 2 to 4 studies. So there is, it's a real shame we haven't got huge data files on thousands of patients with submucosal fibroids. And importantly, leave them alone. Scan them, make the diagnosis, don't interfere, and see how these patients get on. A proper epidemiological non-intervention study. That is what we need. That's what we're crying out for fibroids, adenomyosis, polyps, and cysts, and so on. But what you can see from this review is it suggests, and it is a systematic review, so this is not definitive information. This is just an idea. And it does suggest that a submucosal fibroid reduces implantation by up to 70%. You can see the relative risk of 0.636 and 0.28, and reduces the chance of live birth. So this suggests submucosal fibroids reduce implantation and increase the risk of miscarriage, thereby reducing live birth. So we are probably correct in saying these are mischievous things that we should be advising patients are not good for their fertility. But what we don't have is the randomized data to say removing them is going to be beneficial and not detrimental. But what was also interesting, and this is the first study that really showed this, or the first summary of studies, that these innocent mural fibroids, the ones that we spend so long looking at the endometrium to make sure that it's not indented, not affected, actually also have a negative effect. We can see here that that effect is not as significant as submucosal fibroids. There's about a 10% reduction in pregnancy rate, 20% reduction in implantation when we're looking at IVF, but also 20% reduction in live birth rate because of this significant increased risk of miscarriage. And interesting here, there also appears to potentially, and again I say potentially, an increased risk of preterm birth. Now, if you think 2 centimeters, well, that's pretty small. Surely that's not something to be worried about. Think of how thick the myometrium is. It's about 2 centimeters, maybe 25 millimeters. So if we have a fibroid that is measuring 2 centimeters, then that is actually taking up a significant percentage proportion of the myometrial wall. And yes, the myometrium is going to expand during pregnancy, but remember when these small embryos implant or try to implant, and then when they expand, surely even small fibroids are understandably going to potentially have an issue. And why is that? Is it simply a mechanistic thing? Is it space occupying? Does it stop the myometrium, the smooth muscle, responding as it should do? Or is it because fibroids are actually biochemically and endocrinologically active? We know they produce VEGF, they produce erythropoietin. So they're actually not only just structural issues, they also have hormonal endocrine issues as well. So the summary here is that mural fibroids may be not as innocent as we think, probably not as significant as submucosal fibroids, but we certainly need to give them more attention and not just focus on their size or the fact that the endometrium is affected. Of course, the follow-on question is, should we remove them? Well, I've already explained that we've got very little data on randomized trials on removal of submucosal fibroids, and you won't be surprised that there's even few, if any, good studies on looking at myomectomy versus no intervention or embolization and so on. So again, this is work that really needs to be done, and the sooner the better, so we can advise our patients accordingly. A lot of us like to find pathology and remove it, but actually, are we doing the right thing? Is surgical intervention detrimental in other ways? Does it impact myometrial integrity, endometrial receptivity? And we know, for example, that myomectomies have a very high prevalence of adhesion formation, which can impact upon pain and also natural conception rates. So this is a lady that was referred to me with a history of recurrent miscarriage and from another IVF clinic, and she was told that she had a uterine abnormality. So if you look at this scan here, uterus looks pretty normal, endometrium's thin. She was told, just if you look here, see the endometrium just separates there. She was told that she had a septum or a bicornic uterus. So of course she started to panic. She had, I think, 3 cycles of IVF, something like 4 miscarriages, a couple of natural, and she was understandably completely worried. What should she do? She wasn't being given a definitive diagnosis, and she was really worried that she'd spent lots of money unwisely and wasted her time. So what you saw there is a very simple data acquisition, takes 20 seconds. And what I'm doing now is I'm just standardizing this multiplanar view. So I make sure that the longitudinal view in the A plane in the top left is 90 degrees to the transverse plane in the top right. And then naturally that produces this beautiful coronal plane, the C plane in the bottom left. And now I'm looking through the data set. So I'm using my sectional planes to scroll through. And I do this on every single patient I scan. Every patient, I acquire a volume of the uterus, I look at the cavity, I look at the endometrial myometrial junction. You can see very clearly in the C plane here, they've got a very nice black halo around the myometrium, around the endometrium, I should say. That's the junctional zone. And the black halo is created by the muscle fibers being circumferentially arranged around the endometrium rather than longitudinally, which happens in the outer myometrium, which is why we get that contrast. So this, as you can see clearly, is a very mild arcuate uterus. I use the term mild arcuate because that's how we describe them in my unit. So it's an arcuate uterus. The fundus is normal. There is a very small indentation of the cavity, but this is not a septum. This is not a biconic uterus. So I was able to scan this lady and within 30 seconds to 1 minute tell her she doesn't have a septum, she doesn't have a biconic uterus. She's got a small indentation that we call a mild arcuate uterus. And because of work that we've done and other groups have done, I could tell her this has no consequence. It did not affect her IVF, and it was not the result of her miscarriage. And I think that's a beautiful story to explain how confident we can be with a very quick and simple volumetric scan. We can also use volume ultrasound to understand more about fibroids that we're talking about. So in this first image, we can see, you can probably guess that the fibroid is affecting the cavity, but when we've acquired the volume and we look in 2 planes, we can see in the C plane at the bottom, yes, there's a fibroid, but by rendering the image, so we're just actually shining some light, we're trying to accentuate the tissue density and the contrast between the endometrium in white and the muscular tissue of the myometrium in black. And then in between, we have this fibroid that you can see has an endometrial covering on it, but this is essentially a more solid structure. So pretty clear here, there's a very large submucosal fibroid with a broad base. And I like to show these pictures side by side because there's no way you could, if you're not the surgeon, you couldn't really describe this fibroid to show what you're likely to find in hysteroscopy. But if you actually printed off that rendered image or the coronal plane, it is identical to what you see with the hysteroscope. So a big bossylated intracavity fibroid, very, very easy to remove. You don't need more than 10 to 50 minutes to do this. No point in down-regulating the patient. So the value that you get from the ultrasound, it enormously impacts how I coordinate my surgery, who I get to do my surgery, if it's not me, it usually is me, and how long I would take, so I can use my operative time in a meaningful way, which is extremely important now with COVID, as I'm struggling to get my patients through. And there's the render view side by side. This is another example. Again, I've shown this image quite a few times, but I just still think it shows the purpose very clearly, that we've got a very mild indentation of the fundus you can see on the right. But what we have here is this is a septate uterus, and we have a submucosal fibroid with about 70% extension in the left cornua. Now that is really clear. Again, you print off the image, there is no argument what you're going to find hysteroscopically, as opposed to a 2D report that says there is a uterine abnormality, there appears to be a fibroid submucosal effect. You know again what to expect. So in this situation, we do actually resect the septum and most of the fibroid. We now just use cold scissors for the resection. So this is an old video, but again, I think it shows the beautiful images you can get from 3D that really are very difficult to obtain with 2D or to explain to somebody else, your reader. This is again my World Cup fibroid. Okay, so you'll see why it's the World Cup in a minute. So look at this basic picture, really unclear. The images blur into one. There's probably some degree of adenomyosis here. So you cannot be clear in that picture whether there's a fibroid, if there's adenomyosis. It looks like there's a fibroid, but it's you know, a poor quality image. So what we're doing here is, first of all, as we always do, standardize the image. So we're just getting the multiplane view lined up, A, B, and C plane at 90 degrees to each other. I am not looking at the coronal plane. I am focusing on the A and B plane. Now I'm going to render the image. When you render, the most important thing to do is to reduce magnification and then increase the size of the render box, which you can see here, the square box with the green line. And then, and only then, do you look at the rendered image. And we can see here, we're going to modify the image, manipulate it. And the beauty of rendering is it does give you this tissue density. That's making full value of 3D. 3D gives beautiful spatial orientation, but it also allows you to look at different densities of tissue. And that's important when you're trying to differentiate things like fibroids and polyps, adenomyosis. So it's really, really helpful for myometrial and endometrial disease, and also for some ovarian pathology such as dermoids. And you can see potentially now, and maybe you're not all football fans, but you can see here, you probably are in Singapore. I think that football's a big Formula One in football. So, but you can make out the Jules Rimet trophy there, that gold picture with the football in the hand. So that now we've gone from a very uncertain diagnosis, really hard to work out what's going on, to a definitive diagnosis. So this lady has a normal uterus. She's got a small mural fibroid that's got 50% indentation into the endometrial cavity at the fundus. Very easy to resect. You can be confident there's enough myometrium on the outer side of that fibroid so that you're going to have a low risk of uterine perforation. So we've gone from uncertainty to 100% diagnostic confidence and certainty. So does 3D really help? I think it's pretty clear on that picture. The same applies to, as I said, differentiating from fibroids and polyps. So again, if we look in here on the left-hand side, look at the density of the fibroid. It matches the myometrium. It's different to the endometrium. Whereas if we look at the polyp on the right-hand side, you can see again the tissue density is consistent with endometrial tissue rather than firmer, harder, smooth muscle tissue. Do you need to do this to make these diagnoses? No, and not in most cases. But if you're uncertain, again, apply 3D and look at the different rendering techniques. It may be that the multiplanar view will give you the information you need. It may be rendering will help you. It may be that TUI will help you. But try, and one of them will hopefully give you the answer. I mentioned about, let's just say we get the diagnoses right. What are we going to do about all of these things? Well, of course, the problem is we do not have very good studies. There's one study that shows that fibroids have a negative, polyps, sorry, have a negative effect. And if we remove polyps, it improves the chance of pregnancy. This was a study in Madrid from almost 16 years ago of just over 200 patients with polyps who were undergoing IUI. It's very interesting that half of the patients agreed to be left alone. So they had hysteroscopies, the polyps were seen, biopsied but not removed, and those patients then continued to have treatment. It's a very strange study that the patients have been willing to do this in the first place, and we've reviewed this in our Cochrane review, and the authors have not contacted us and won't respond to us. So I question whether this is real data, but regardless, it's the only study we have. So despite most of us being confident that polyps are detrimental and should be removed, actually we have very little evidence to support that notion. Again, I think that's a real shame and something that we simply have to address along with fibroids. Just briefly, again, about operative planning, I think this is a slide, and I show this to a lot of my new trainees. These ladies have polyps. It's a pretty easy diagnosis. You can see the hyperechogenic structure essentially in the endometrium. But what I want to really pinpoint here is that on the left, we have a spherical polyp. You can see in the coronal and the render view at the bottom, that is a pedunculated polyp, easy to remove in the outpatient department, very low risk of recurrence. If we look on the right-hand side, what we've got here is the polyp is more elongated, and that's because it's broad-based. It's attached to the left lateral side wall of the uterus. This is harder to remove, and it's probably going to need a very gentle but superficial resection. If you simply just try to curette this or remove it with polyp forceps, there's a high risk you're going to leave an active base, and that polyp may well then come back. Also, using images like this will allow us to prospectively look at polyps and say, which of these polyps is more likely to have a detrimental effect on fertility? Is it the pedunculated ones, or is it the broad-based ones? And when I ask that question in a live audience, face-to-face, people often say, well, it's the broad-based ones. But actually, if you observe the pedunculated polyps, they often tend to move up and down the uterus, a bit like a ball bearing. You can imagine the potential impact that would have on an implanting embryo. So I'm not sure, and I don't think the data will allow us to be confident either way. If you are not certain, you can always put some saline in. Saline will give you a diagnostic answer in many cases, and if it still doesn't, you can acquire the volume. So again, I do this in all my patients. I introduce saline through a very simple catheter. Because we have lots of embo transfer catheters, that's what I use, but you can use a dedicated balloon catheter, or you can use a pediatric Foley catheter. Essentially something that's sterile and you can pass through the cervix easily. Inject the saline and acquire the volume as you're injecting, and you get these beautiful expanded images of the endometrial cavity. Briefly, ovarian cysts. So we've got a collection here of hemorrhagic cysts, endometriomas, dermoid cysts. So again, I think according to IOTA, we should be 100% on these. There should be no diagnostic uncertainty. The only cysts that we're allowed to get mixed up, and I think for obvious reasons, is a dermoid, because they're complex and they differ. But we really should not be questioning, is it an endometrioma? Is it a hemorrhagic cyst? They've got very different characteristic appearances, very different, and we need to be definitive on these. But the question is, if you find a cyst and you diagnose it correctly, do they affect fertility? Are you less likely to conceive if you had an endometrioma, but you're ovulating? Same applies to hemorrhagic cysts. Same applies to dermoids. Well, we often sort of always lay the blame on the endometriomas, but if you've got a hemorrhagic cyst, many of those cysts are actually hormonally active, producing estrogen, producing progesterone. And we see this in some women with Mirena coils, that there's an extra element of serum progesterone coming from the cysts rather than the Mirena coil. And many of those women end up with menstrual dysfunction and so on. So it's not just anatomical here, there's a hormonal consideration as well. This is a dermoid. Again, do dermoids affect fertility? Well, there's no evidence that they do. And if you're trying to conceive naturally, apart from the risk of the dermoid torting, which of course is its major risk, but interestingly, in a very large observational study, prospective study, most dermoids actually don't tort. We know that they're more likely to tort than other cysts, but most don't. The issue we have in IVF, if we put a needle into this at the time of egg collection, there is a much higher risk of infection and of chemical peritonitis. And that's something we clearly need to avoid in young women trying to conceive. Here, a series of endometriomas. And as I said, yes, we talk about ground glass, but I think whatever diagnostic criteria you apply, the use of some basal papillations and so on, it's pretty much a very clear diagnosis to be made. This is an endometrioma. There is no evidence of hemorrhage here at all. So the key here again, there's no evidence endometriomas have a detrimental effect on conception. It's more to do with, are they affected? Is there peritoneal endometriosis? And that's going to be the bigger issue. But we also have the same problem that if the needle goes into these at egg collection, then there's a much higher risk of infection. And that infection can actually be very severe and resistant to antibiotic therapy. So it's something we need to make our patients aware. Yes, we don't need to remove endometriomas. And again, I'm not even going to mention size, but if we needle them at egg collection, there is this risk of infection that may not be preventable. And I think then you and your patients decide, should you therefore undertake surgery, which is not without risk, and of course can reduce ovarian reserve. And in contrast, here we have some hemorrhagic cysts. They're very different. You do have different appearances depending on the level of fibrin organization. So the classic spider web nevi, then as the cyst has been staying along, which you can see on the right side, the clot starts to form and you get organization with breakdown into the different components of the blood, the serum and the red cells. So often considered benign. I would just recommend check or think about checking estrogen and progesterone levels in some of these patients. So just going to move on now a little bit to ovarian reserve. So when we look at ovarian reserve, we can use ultrasound or we can use AMH to assess that. We've made a decision. We've got to decide what protocol do we use. So there are many different protocols. What drug do we use? What dose of drug? What do we use to trigger final oocyte maturation? And do we modify our luteal support and give any adjuvant therapies? I have to say, I've already explained how unclear we are about some of the impact of ultrasound pathologies. When it comes to working out what the right protocol is, I think we're going to be arguing this even when I'm long gone and been in the ground for 20 years. It's a real shame because we've got great tests of reserve now. And we really need to start to limit or have set recommendations. Now, we did some work about 10 years. We were looking at the role of ultrasound against AMH. And again, we use both in my clinic, and I'm a big fan of AMH, but I think too many people underestimate the information gained from an antral follicle scan, and there's reasons for that. So I think this is a really important slide, and I just wanted to take a moment to look at this. So this is a scan of an ovary. We're going to do an antral follicle count. You've got to maximize your 2D settings. You've got to look at getting the focal zone in the right place, using the right resolution, making sure the angle is right, because that's going to affect your frame rate. Here, I have deliberately reduced my frequency and increased my gain. It doesn't give the clearer image, but it made the follicles become more apparent. So ultrasound, particularly 2D ultrasound, is a very dynamic thing. You've got to be able to modify the image to accentuate what you want to look at. And when you're looking at follicles, the follicles need to stand out. So you might need to use a different approach than when you're looking at stand imaging. And we've just worked on a white paper with GE that will be available, looking at basic 2D settings to maximize follicle counts, the appearance of the endometrium and so on. So we can see here, these are all the same ovary, but just using different displays. And you can see in the bottom left image, yeah, you can make out the follicles, but they're unclear. But if you take some time and consideration, you can get very clear images where the follicles are pinpoint and they're defined. Unless we take some time to improve our image quality, you are not going to get an accurate, reliable antral follicle count. You can't just scan and quickly scroll through the ovary and count follicles and expect to get a reliable, reproducible follicle count. You've got to spend some time doing this. So the key to an antral follicle count: set up the machine correctly, take your time, and count the follicles twice. Alternatively, you can use 3D. So this is an image of an ovary. I'm going to just skip to the next one to show you the role of automation. So we've drawn around the ovary with vocal, and then we can look into the ovary, and we can use SonOVC to automatically look at the number of follicles and their sizes. Now, SonOVC doesn't give the most accurate measurements when looking at small follicles. I use it more for just number. When you use SonOVC, what you will find is there are many more follicles than you think. It often misses many follicles. You can see here. So some of the follicles are clearly not spherical, so don't worry about the shapes. But what I can do is I can go through the volume and I can add the follicles that are missed. So we refer to this as semi-automated process. And I find that when I use 3D and SonOVC, as I said, there's probably 30% more follicles than I think with 2D. And when we look at the literature and we compare AMH to follicles, what you'll find in most studies is the AMH is much higher than the follicle count. And that says one thing: we're not counting enough follicles. So I think in many situations, antral follicle counts, when not done properly with 2D or 3D, are underestimating true reserve, and that's why patients don't respond accordingly. So if you use antral follicle counts correctly, you will find yourself as accurate as you are with AMH, and indeed, in my view, often more so. I am confident when I scan that we can be pretty sure the antral follicle count is within the right range. And this is why I like it so much. So this is a study we did of about 100 patients. We've now done it on 5,000. And you can see along the bottom, we've got the antral follicle count, and then we've got the number of eggs retrieved at IVF. What we want is 100%. We want 20 follicles, gives us 20 eggs. 30 follicles gives us 30 eggs. We don't want 30 eggs, of course. But we want to be able to titrate the predicted ovarian response to the number of eggs. So what we notice when we use 3D is we have this range of about 0.77. So that means if we've got 10 follicles, we'll get around 7 to 8 eggs. If we've got 20 follicles, 14 to 16, and 30, 21 to 24, based on about a 70% yield. Now, of course, we can modify this. If I've got a patient with a follicle count of 10, I can maximize my protocol and drug dosage to try and make sure I have 100% yield. If I've got a lady with a follicle count of 30, I could modify my response to try and get a yield of 50%. So we talk a lot about ovarian reserve. What we really need to focus on moving forward is ovarian response. And what is that percentage number that we want? Do we want 100%? Do we want 25%? Do we want 75%? And for me, I can only do that in my head. I'm a very simple person. I can only do that with scanning and follicles. I can use AMH to fine tune it and to make sure that I'm not wildly wrong with my follicle counts. But I find this very, very reassuring. We call it our PIN number, our personal egg number. And I think patients understand this as well. And when we did this work, we actually looked at the relationship between egg number and IVF outcome. And again, you may have seen this. This is, again, over 10 years old now. And what we noticed is the number of eggs we collected was actually a direct determinant of the chance of live birth, not pregnancy, but live birth. And that applied irrespective of age and irrespective of the years of IVF. You can see here. There was a plateau at around 15. And interestingly, more studies have now come out looking at cumulative live birth. So not just the fresh cycle, which is what we looked at, but actually the subsequent frozen cycles from that original IVF cycle. So actually, the more eggs we get, the better. There's no plateau. It actually keeps on going up. So if we get eggs are critically important, so you need to maximize your response. And this is another study by Nicholas Policios. Again, a really nice study. There's some limitations because it's retrospective, but fantastic numbers, 15,000. And again, it shows that there is a plateau in the fresh cycle, but this cumulative live birth rate with those frozen ones keeps on going up and up and up. So essentially what we're saying is more is better, providing you do it in a safe manner. I just want to finish off a little bit, just again, about some work that we're doing here, and then we'll pause for questions. So antral follicle counts, very important. I need them to run my IVF unit. I need them to dose patients. But what we're starting to look at now is maybe we could simplify things. So instead of actually counting follicles and being definitive, 10, 12, 20, what if we just actually look at pattern? We can see here the lady on the left, they haven't got many follicles. The lady on the right, this is more like a polycystic ovary, there's multiple follicles. And the ladies in the middle, they're okay, they're somewhere in between. So actually, rather than specifically know the follicle count, could we just subjectively look at the ovary and say, poor responders need to go on protocol X, potential over responders need to go on protocol Y, and everyone else on protocol X somewhere in between. And I think that's something that we will see more of in the future. And of course, it's got most relevance here. So PCO, it's still one of the most enigmatic diseases or conditions, I should say. And again, I mentioned at the beginning, I know this is a particular issue in Asia, and there is a genotypic issue here. What's really strange about PCO is, yes, there's a follicle number. I think some degree too much emphasis is placed on that. We can see here some of these patients in the bottom images have got hundreds of follicles. So this idea of whether it's 12, 19 or 20 follicles in an ovary, we're talking often patients having 30, 40, 50, 60 follicles. But as you can see here, this lady is spontaneously ovulated. This is no medication, no clomiphene, no letrozole. And the bottom left image, you'll notice actually there's a little fetus there. So we have people with profound PCOS who are oligomenorrheic, who've got hundreds of follicles, AMHs of 100 plus, who still ovulate, who still conceive, who don't miscarry. And yet we've got patients with lower numbers who respond very strangely to IVF, don't respond, then over-respond, and produce many poor quality eggs and many poor embryos as a result. This so much more work needs to be done here. Again, it is really a black box of science that we need to tap into. And you can see, it's been described over 100 years ago, PCOS now. So we really, I think it's a bit shameful that we don't know more about this, and we really need to focus on it. Ultrasound is going to be a key part of that study. Okay, I just think it's taken me a little bit longer than planned, maybe just at the start. So what I wanted to do, I think, in terms of monitoring response, let me just think a little bit about that, and then 5 more minutes, then we'll stop. So follicle tracking, been doing it for years. 1985 was the first transvaginal follicle tracking scan. Started in Dallenbach in New York, was monitoring. It's still debatable of how many follicles do you need and what size should they get to. 17 millimeters, 18 millimeters. There's very few studies, and again, I show you just 4 here, that some suggest prolonging stimulation is beneficial, some say it makes no difference, and so on. So despite having done thousands and thousands of millions of cycles of IVF, there's still no universal agreement of when is an ideal time to trigger a patient. Part of it, I think, relates to the uncertainty about follicle tracking, and you can remove that uncertainty by using Sono-ABC. This is improved enormously. Now, again, it won't be perfect in all cases. Sometimes you will need to measure individual follicles, but that's fine. What you're doing then is you're only having to measure 1 or 2 follicles, but Sono-ABC will take care of most of the work for you. And some people say, well, the measurements can't be that accurate. I can almost guarantee you they're going to be more accurate than me and you. Trying to measure what really isn't a perfectly spherical structure, measuring it in 2 or 3 planes, is something we're always going to struggle to do. I'll just get to embryo transfer and stop at that stage. So oocyte retrieval, for those of you who do IVF, again, a lot of should you aspirate or should you just drain? It's taken me many years. I grew up on flushing every follicle possible, and now I flush nothing. Potentially, maybe if we've got 1 or 2 follicles, but really we rarely flush. There's a lot of studies. I show you just one summary of the Cochrane review, showing even in women with poor response and low follicle numbers, there is no evidence of an improvement in egg retrieval or in clinical pregnancy rate. And there's some evidence now that it's detrimental. It actually tends to increase time, increase pain, and cools the eggs down. So very, very limited benefit in flushing. And I'll finish on this one, embryo transfer. So I think it's a nice way to finish. It all builds up to getting the embryo and putting it back. Very straightforward. Few studies say ultrasound is not important, it doesn't help. I could not imagine any of my patients not wanting to see this picture. They've been going through this for several weeks, if not years of trying. and you can see the lovely fact that embryo has been implanted there at the end. We withdraw the catheter, and you can see that hyperechogenic area where the embryo or embryos have been deposited. What a wonderful way for the patient to leave the clinic in the knowledge that, yes, they're not pregnant, but they've got an embryo in the right place at the right time. So ultrasound may not necessarily help with embryo transfer, but it's an important part of the process. But I'll leave you this image to make you maybe some food for thought. What you can see here, this is a coronal plane of the image, and you can see the deposit of the embryo there, the white bit at the top. Look at the myometrial contractions. Endometrium is a static substance. It is glandular. It doesn't move. Look at that moving. So this is the sub-myometrium. This is the junctional zone. There are contractions at the time of embryo transfer. No wonder some of these patients end up with ectopic pregnancy, or potentially these embryos are actually expelled while implantation doesn't occur. So we've known for a long time that endometrial contractions may have a negative effect, and the studies looking at smooth muscle relaxants, such as atozovan and so on, to actually improve success of embryo transfer. But also the question is, why are we getting so many contractions? A lot of it relates to difficult embryo transfers, and that's certainly something you can reduce or improve by using ultrasound to guide your transfer, help you get through the cervix in a simplistic way that causes the least trauma possible. Right, I'm going to pause at that point because it probably take me just as long to go through endometrial receptivity in early pregnancy, and maybe we could come back and do another webinar on that one. So I'll stop at that stage and invite some questions just for the sake of time, if that's okay, JJ.
Thank you very much, Dr. Nick, for sharing the fantastic information. And I hope
you're
you
on mute,
all.
JJ. I can't hear you.
Yes, this amazing presentation. Now, Dr. Nick will answer some questions that were sent to us during the presentation. Just a reminder to participants, please be sure to type your question in the question box in your control panel and click send. So, Doctor, right now we're waiting for the question. So I have a question to you. What in my question, what about the tip for evaluate the fibroid with have the isoechoic pattern? This is difficult for evaluate with 2D, right? What about your experience in for tip and trick for evaluate that is a 2D or 4D will helpful?
Yeah, so it's a good question. So as I showed, I think what I would say is some fibroids, you're going to struggle. If you've got a very large uterus and multiple fibroids, whatever you do, the images can be very poor, and then you're going to, it's going to be difficult. Sometimes in those situations, the only way to get around it is to do an MRI. But before you do that, you need to maximize your 2D and your 3D. So a lot of it, if you've got a large uterus, you need to reduce your frequency. So drop down to penetration mode, for example, modify that. Using a high frequency and harmonics is going to create more shadowing, and it's going to lose resolution. Well, certainly in the farther field. So using the bandwidth of the probe, which is so good with the GE probes, using a lower bandwidth, the modifying gain and dynamic contrast will help. I then would do a 3D picture, and I'd apply the same concept. You can modify SRI, you can modify the gain on a volumetric data set as well. And then I render the image, because rendering gives you that ability to show depth. And hopefully I showed my World Cup fibroid, my golden one, how the first image was terrible, and yet at the end it was crystal clear. If you're still struggling after maximizing 2D, after acquiring a 3D volume and rendering it, then use some saline, because saline just gives that contrast and it allows you to see clearly. So hopefully that's some help there.
Okay, thank you. Move to the next question from our participant. Do you use ultrasound to access endometrial reproductivity? If you so, how do you use it?
Yeah, absolutely. I was going to just move on to show you that. So again, just briefly on that, there's two concepts of endometrial receptivity, which is pathology. So we briefly touched upon that. So if you've got a fibroid or a polyp or adenomyosis, do they affect receptivity? I think the answer is they do, but not in everybody. So there will be people out there that have got adenomyosis that conceive naturally with no problem at all. And the same applies to fibroids. So unfortunately, it is still a mystery of that. So that's pathology. But the other thing that we're looking at now really carefully with is endometrial pattern. So if you look at all the studies in IVF, everybody is obsessed with thickness. So you measure the endometrium, and the latest data suggests if it's more than 7 millimeters, it's okay. So if it's under 7 millimeters, it's a problem. And if it's 7.5, it's not a problem. I struggle with concepts like that. I don't think this is black and white. So I think endometrial thickness has got relevance. But there are some people with thin endometria under 7 millimeters that's normal for them. And there are some people with endometrium of 8 or 9 millimeters that the endometrium is not receptive. So I would recommend you look back at some of the data from the 80s and 90s on pattern. So there's some really good studies looking at, we know the endometrium adopts a triple pattern, and then it becomes homogeneous and it goes through this intermediate phase. And that's all to do with estrogen and the transference over to progesterone dominance. So actually, if your endometrium maintains a triple pattern, that's detrimental. And if it becomes homogeneous too soon, that's detrimental, because you've got to have the right estrogen progesterone ratio and change to make it receptive. And that's the concept of the ERA study, the endometrial biopsy and the genetic assessment. So, you know, the endometrium has a genetic receptivity picture. So I would urge you, don't just focus on thickness, measure it, but look at the pattern, spend more time focusing on what the endometrium looks like and how it changes across the cycle or within the IVF cycle. And I think that's one reason why a lot of the studies and most of the work's been done in Asia, which is fantastic data on freeze-all. And what we do know now, women that are likely to benefit from a freeze-all strategy are those who over-respond. But why is that? I think it's because the endometrium is out of sync. It's advanced too much because of imbalance of estrogen and progesterone. And we've got some data that we hopefully will present next year to show that.
Okay, we move to the next question about the position of the uterus. The question is, how do you deal with a uterus in mid position or adherent to the anterior pubic wall?
Yeah, again, very, very good question. It's one of those things that fortunately doesn't affect everybody, but some. And when you do it, it's really difficult. So the axial uterus that's right at 180 degrees to the probe is a nightmare, I'm afraid. It is difficult. The key thing is gently move it. So I use a lot of manipulation of my probe when I'm scanning patients. I do warn them. I always tell them I'm going to press, and I press gently and move. So you can modify the position of the uterus in many patients. Bladder will also affect it. Sometimes an overfull bladder or filling the bladder may help. It may induce retroversion, and if you're retroverted, sometimes that helps as well. But the key, women who have axial uteruses are often the postmenopausal women, and they're very difficult to scan. So what I would do, if you cannot improve the position with gentle pressure of the transducer, the best thing to do is have a break, get the woman to comfortably fill her bladder and do an abdominal scan. So the image I showed you of embryo transfer, the quality of the abdominal scans with the Voluson systems is amazing. If I could hide the top bit of the picture, I think some of you would mistake abdominal scans for transvaginal scans. So fill up the bladder comfortably, do an abdominal scan, and the minute you do an abdominal scan with these axial uteruses or the ones that are adherent to the anterior wall that you've asked about, you have a beautiful 3D picture. That's the natural picture because it's at 90 degrees. So I think abdominal scanning is very underrated in that situation. Try that. I guarantee you it will help.
Okay, thank you. And then the question is, do you measure and count all mandible if we have the fibroids 10 past?
Yes, I saw that's a question for Mario. It's a really good question. My personal view on that one, Mario, would be if you've got lots of fibroids, I think that it's probably to some degree meaningless of whether some are submucosal, some are they're going to be everywhere, aren't they? I think women with multifibroid uteruses, they're the ones who are much more likely to have a problem. And I think that's where myomectomy, potential embolization, but myomectomy has a significant role. I don't think measuring every single fibroid and trying to quantify them is helpful. I'm not sure it's even practical. But that is a situation where I would potentially look at MRI to try and work out what I'm going to do operatively. Because if you do myomectomies, they can be very difficult operations, and knowing exactly where a fibroid is you know, particularly if it's close to the broad ligament and you've got risk of vascular injury or close to the cervix, it can be very difficult to operate. It allows you to have that discussion with the patient about surgical intervention. So I think I wouldn't even say 10. I think, you know, maybe five or more. If you've got multiple fibroid uterus, I would say, based on the data I showed you, that mural fibroids without any endometrial effect still have a negative effect. When you multiply that by several fibroids, I think it's much more likely to be an issue. What we're lacking, unfortunately, though, is still a really nice study to show myomectomy in that situation is better than no intervention, and also where embolization comes into it. And this isn't just conception. Remember, women with multiple fibroid uteruses in pregnancy, they're the ones that have a much higher risk of fibroid degeneration, bleeding, pain, preterm delivery, and postpartum hemorrhage, which is a big issue around the world.
Okay, we move to the next question. Are isolated myometriosis significant in infertility without any other ultrasound findings of endometriosis?
Yeah, again, a very good question. These are excellent questions. I shall write them down actually and make sure I put them in my next presentation. So thank you for that. So yeah, we see a lot of these myometrial cysts. What I would say is, I think if we put the other signs of adenomyosis together, so we have echogenic lesions, subendometrial myometrial cysts, and this shadowing. I think when you scan patients often who are completely healthy, have no problems, and you see these small cysts, and you do see sometimes hyperechogenic nodules. I have to say I personally ignore them. I think that if you look at the criteria for adenomyosis, without doubt, well, I say without doubt, I think I would be pretty confident the most important one is disrupted myometrial endometrial border. That for me is where most of the data comes from. It gives you the most diagnostic confidence. It's got the most similarity with what you find histologically. So you'll often find a myometrial cyst that you're describing here, all these echogenic lesions with an intact junctional zone. I think they're just benign pathology. It's probably some glandular issue, some cystic thing like a Nabothian follicle, but within the myometrium. So I think they have no relevance. But one thing I would say on that is to be sure before you write them off and ignore them, do a 3D, get that junctional zone. You can see it in the coronal plane, but it comes out beautifully in a rendered image. If your junctional zone is intact and you can see it all the way around, I think you can tell that woman she's not got adenomyosis, and don't worry about anything else that you see.
Thank you for question. And another question is, any tips or differentiation of subserous versus intra-alimentary fibroids?
Yeah, that's another good question for Mara there. I think, again, for me, when I'm trying to differentiate anatomical position, which, I mean, your question's a good one, but it could apply to many different things, couldn't it? I would acquire the volume and make sure you get a volume that isn't just what you're looking at, it's the bigger picture. So it's the uterus, the fibroid, as much as you can. Sometimes that will require an abdominal scan actually, but if you can get a bigger picture, so you've got some images around the side of it, and then apply TUI. Because what you'll see with TUI, like I showed you with the ovarian cyst and hydrosarpinges, it gives you this spatial orientation. And if you then look at the uterus and your fibroid, and I think you will quickly identify its position. The same applies when you're looking at interstitial pregnancies. It's a beautiful technique when we've got these pregnancies that are high in the uterus. If you do a 3D image, TUI or a render view, or just simply using the multiplanar view, the patient will say to you, that looks like it's in the cavity, or it really makes it crystal clear. I don't think you can do it with 2D. I'm sure some people who've been scanning for many more years than I have can, but what they're doing is they're creating a 3D rendered or TUI image in their head. But if you've only been scanning for a year, you've got it in front of you because you just apply the images. So it doesn't necessarily mean rendering or multiplanar view. It could be TUI, but acquire the volume, big broad volume, and then you can flick between those different image displays very quickly, and I think it will come out very straightforward where the position is.
So in usually you always use the multiplanar function. Usually in your new for you, right? That I saw.
I'm a big fan of the I think okay. a lot of my staff, we have a lot of nurses that scan in my unit, and when they come to show me a picture, I'll be doing the meeting after this, so I'll review all the scans in the morning, and often they show me pictures of, is it a polyp? You know, all these questions we've been discussing. And many of the images are rendered. They show me the picture with the render on, and I immediately tell them off and take it off. I like a multiplanar view that's standardized. So the A, B, and C plane are at right angles up. And then you put your reference point in the middle of where you're looking at. So if they want to show me a polyp, I want that dot in the polyp. If it's a question about a pregnancy, you know, is it definitely a pregnancy in the uterus? Multiplanar view, standardized, and then you put your reference point in the bit that you're looking at. The minute you apply rendering, it takes away some of that image because you lose some of the view. So rendering's got a role, but I tend to use rendering more for looking at that single rendered image. But the multiplanar view, if I could have one view only, one view, 2D, 3D, you name it, it would be a multiplanar view, properly standardized. Then I'd be very happy.
Thank you. I happy too. It look like we have covered all for our questions. Okay, thank you again, Dr. Nix, for answering those questions and for the great presentation today. It was a pleasure to have you with us today. So in conclude the webinar, thank you all for attending. We hope you are enjoy and learn with this presentation. We will see you next time. Have a good day and good weekend. Thank you again for joining. Goodbye.
Goodbye, everybody. Thank you very much.
Thank you. Goodbye.